system, obviously. Now, we've had some questions in the past on whether or not we should use a bipolar recording or a referential recording. So, in other words, a one-channel or a two-channel electrode system. Two channels always better, all right? Recording left and right, especially on a thyroid, this is absolutely essential. For an ACDF, this would be nice as well. However, if you need your channels for more muscle coverage, it's okay to reference left and right. You don't have to do a bipolar recording. So do bipolar whenever you can. Do bipolar always on a thyroid or a parathyroid, and then reference only as needed. That's the answer to that. All right, so some important points when placing the electrode, the tube with the electrode in the patient. Always request that anesthesia induces with succinylcholine, and that they do not use lidocaine, all right? Because lidocaine will deaden the nerve, and so you won't see your baseline activity. And of course, muscle relaxant is a no-no for these cases, and it's very important that you're able to record baseline activity immediately after intubation, because what I'm going to tell you is that you don't want quiet EMG. Unlike your spinal EMG, you should have background activity. And that's going to confirm that the electrodes are against the vocalis muscle. The tonic resting state of the vocal cords is contracted. All right, so that muscle at rest, if you will, when you're not speaking, is actually contracted, not resting. The muscle only relaxes as you speak. So you should see activity on the cords. If you don't see activity, you either have a misplaced tube or electrode, excuse me, or you have muscle relaxant on board. And so we need to get rid of that one variable, that muscle relaxant. So we ask them to use SUX. Now, if they insist on a non-depolarizing agent in order to avoid fasciculations, you may suggest that they use a much smaller dose of rocuronium, about 5 micrograms, co-administered with the succinylcholine. This will stop the fasciculations, and that's very uncomfortable for the patient post-operatively. That's their concern. This has stopped fasciculations and will also give you the benefit of a short-acting depolarizing muscle relaxant. Okay? We should always ask the anesthesia personnel to visualize the electrode touching the cord. So the blue strip, the electrode, should sit right between the false vocal cords. They should visualize it. Okay? That's the only way to know for sure. And then, of course, placed correctly, you're going to see that baseline activity. It should be about 50 microvolts in amplitude, give or take. Usually my sensitivity is set around 200 microvolts per division. And again, if we're too quiet, we might have a tube that's not at the cords. The electrode's not at the cords. It's either too superficial or too deep. You may have a patient that doesn't have 4 twitches. You may have a rotated tube, which you could see some asymmetry in your right and left. Or they may have used lidocaine. Here's an example showing an asymmetry. So in the beginning, you have nice activity, baseline activity on the right side, and you still see some activity on the left, but it's of different amplitude. So in this case, the tube is very likely rotated. I also want you to know that this was done on a Nicolay Endeavor, and so you're going to see 2 seconds here. That's a 2-second window, okay? Just so you realize that. That's the way the Nicolay does. For instance, 20 milliseconds. This is not 20 milliseconds per division, but rather 2 milliseconds per division. It's a 20 millisecond window. So when you're looking at these slides, please don't think we have a 20 millisecond per division window. That would be obviously incorrect, because I told you a few slides ago that your latency is going to be around 2 milliseconds for your RLN stimulation. Here's an example of pathological training on the RLN. You see it bilaterally. Right. Probably this is happening on the right, and we're getting far field recording on the left. Right. Now, here we were stimulating directly at 3 milliamps due to a surgeon request. This is not recommended, but you can see a nice stim artifact. It's really nice on our control. We have a control in the trapezius here just to show a stim artifact with no response when we stimulate. Here we are stimulating at 1 milliamp, and you see a CMAP on the lower window here on the right. Okay. And notice the onset is about 2 milliseconds. Right? If it were 200, you wouldn't see it. It would be right over here buried within your stim artifact. And that's a very, very common mistake. You'll notice here on the control, again, remember I told you the control was the trapezius. You see this? That's EKG. All right, you're recording EKG. All right, and you can figure out the frequency. All right, so if this is a 2-second window, right, and we have 4 responses, what do you think we have? Well, if there's 60 seconds in a minute, all right, and there's 4 responses, we have a heart rate here of about 120 beats per minute. Especially a little tachycardic. Right, you're getting 4 responses in 2 seconds. So how many is that in 60 seconds?